minimally invasive combined approach for recurrent ureteropelvic junction obstruction and nephrolithiasis after laparoscopic pyeloplasty using a paclitaxel-coated balloon. A 57-year-old female with a history of right laparoscopic pyeloplasty performed 10 years ago and with no subsequent urological follow-up presented with gross hematuria and right flank pain, without fever or other symptoms. Laboratory analysis showed a blood creatinine level of 0.76. The urine culture was negative for bacterial growth. The renal scintigraphy revealed a slow washout of the radiotracer from the renal pelvis, suggesting obstruction at the ureteropelvic junction. After diuretic administration, the tracer failed to clear and remained pooled within the renal pelvis, confirming functional obstruction and impaired urinary outflow. A contrast-enhanced CT urogram revealed right-sided hydronephrosis with delayed contrast excretion, along with multiple calculi located within the renal pelvis and calyceal system. After a thorough discussion of the available therapeutic options and upon obtaining informed consent, a combined approach was planned. The patient was scheduled for surgical management consisting of a mini-percutaneous nephrolithotomy, combined with retrograde pyelography and balloon dilation, using a Paclitaxel Dextran coated balloon to address the UPJ stricture. Step 1. Retrograde pyelography. The procedure was performed under general anesthesia with the patient in a modified supine position, as described by Giusti. Standard aseptic and antiseptic measures were carried out, and the operative field was prepared and draped in a sterile manner. Initially, cystoscopy was performed to identify the right ureteral meatus. A 0.035-inch hydrophilic guide wire was advanced under fluoroscopic guidance into the collecting system, followed by a retrograde pyelogram, which revealed a 1 cm stricture at the UPJ. Step 2. Ultrasound-guided percutaneous puncture. An ultrasound-guided percutaneous puncture was made into the middle calyx, followed by fluoroscopic-guided tract dilation. A Karl Storz MIP-M system was used, incorporating a 12 French nephroscope with a 12-degree downward view and a 22 cm working length, together with a 15.5/16.5 French access sheath. Step 3. Shoyag laser lithotripsy. This setup allowed clear visualization of multiple calculi within the renal pelvis and calyces. Holmium dye YAG laser lithotripsy was performed, achieving complete stone fragmentation and removal through the vacuum cleaner effect. Flexible nephroscopy. However, due to the unfavorable angle of the lower calyx, direct access with the sheath was not possible, requiring the use of a 7.5 FR flexible ureteroscope to fragment the remaining calculi. Step 5. Predilatation. A hydrophilic guide wire was advanced into the upper calyx, and predilatation was performed using a non-drug-coated ureteral balloon. A 7 mm by 60 mm balloon was inflated to 12 atmospheres for 5 minutes, successfully traversing the UPJ stenosis. Step 6. Paclitaxel/Dextran coated balloon dilatation. A paclitaxel plus Dextran coated balloon, Elutax, was then utilized to achieve mechanical dilation of the stricture while simultaneously delivering the drug circumferentially. A 7 mm by 60 mm drug-coated balloon was positioned and inflated to 12 atmospheres for 5 minutes under direct endoscopic visualization. Step 7. Nephrostomy and end of the procedure. All instruments were then withdrawn. An 18 French Foley catheter and a 10 French nephrostomy tube were placed. No double J stent was left in situ. 2 weeks later, the nephrostomy tube was clamped and subsequently removed after confirming satisfactory urinary drainage. At the 1-month follow-up, renal ultrasonography showed complete resolution of hydronephrosis with preserved renal function.